So we'll be starting with the free paper session. May we have the chairpersons for the session, Dr. Harshvardhan Shukla, Consultant Head and Neck Surgical Oncologist at HCG Cancer Center, Ahmedabad, and Dr. Yusuf Mistry, Consultant Head and Neck Surgical Oncologist, Safi Hospital, Mumbai. So I would like to call upon moderators for the session, Dr. Deepen Patel, sir is judges. Dr. Deepen Patel, sir is a Senior Consultant Surgical Oncologist at Zydus Cancer Center, Ahmedabad. Dr. Jayesh Sharma, sir is a Senior Consultant Surgical Oncologist based in Raipur. And Dr. Sachin Wani, sir, Senior Consultant Surgical Oncologist at HCG Cancer Center, Vadodara. Sir, can we have all of you on chairs, please? So, I call upon Dr. Mamta for the first free paper session.
So, I am Dr. Mamta Patel, FHNO Fellow at HCC Ahmedabad. Will be presenting our experience with intraoperative neuromonitoring and parotidectomy. Our experience with intraoperative neuromonitoring in parotidectomy. So, common complication after parotidectomy, that is facial nerve paralysis. Parotidectomy with intraoperative neuromonitoring, does it reduce the incidence of facial nerve dysfunction? What is its role? So these are the following nerve injury rates in the literature. So average being 0 to 70% of temporary paralysis and 0 to 19% of permanent paralysis. Coming to review of literature, few papers. This was a paper by Estumba et al. Intraoperative neuromonitoring for facial nerve during parotid surgery. It was a study in Spain. So in Spain, 94% of the surgeons who are doing parotidectomy are using neuromonitoring device. Another paper by Terrell et al. Clinical outcomes of continuous facial nerve monitoring during primary parotidectomy. It was a retrospective analysis of 56 patients favoring neuromonitoring device. On the paper by Lopez et al., usefulness of facial nerve monitoring in surgeries of parotid gland. Also 52 parotidectomies favoring facial nerve monitoring device. On the paper, continuous facial nerve monitoring during pleomorphic adenoma recurrence surgery by Mekes et al. Again, continuous facial nerve monitoring reduced the incidence of facial nerve paralysis. One of the prospective analysis done by Mekes et al. Again, 100 patients, 50 each, favoring neuromonitoring device. What are the benefits of IONM? Assess the functional integrity of the nerve, monitoring and localization, detection and prevention of the neurological insult, and prediction of postoperative facial nerve function and related counseling to the patient and relatives. Distinguished from the non-neural structures, improved patient outcomes, and reduction of duration of surgery. So methodology and equipment, ours was a retrospective analysis at HCG Ahmedabad, which was done from 2009 to 2024. So 2009 to 2017, we have operated patients without neuromonitoring device, and from 2017 to 2024, we had operated with neuromonitoring device. So the sample size was different for both the groups. For group 1, it was 54 patients, and for group 2, it was 92 patients which were operated with neuromonitoring device. And it was, the device was NIM Response 30 Medtronic. So after proper earthing, followed by electrode placement and closing the circuit, continuous neuromonitoring intraoperatively as well as post-operative, followed by clinical assessment of nerve injury based on House-Brackman grading scale as normal or mild dysfunction, moderate dysfunction, moderately severe dysfunction, or severe dysfunction, or total paralysis on post-op day 1 and post 3 months and post 6 months. So data of demographics and tumor features. So females were more commonly affected in both the groups than males, and benign were more compared to malignant lesions, and pleomorphic adenomas were more in both the groups compared to others. Coming to the nerve injury assessment at post-op day 1, post 3 months and post 6 months. So in group 1 with 54 patients without neuromonitoring device, almost 37 patients had normal facial functioning, and all of them, most of them has improved over a period of 6 months of time. That is 88.9% had almost normal functioning at the end of 6 months. In group 2 with 92 patients with neuromonitoring device, the assessment post-op day 1, 3 months and 6 months, so 72.8% had normal functioning of the facial nerve post-op day 1, and 97.8% has recovered over a period of time. So there is significant difference between two groups. So we have again divided them into two, whether it was a primary surgery, whether it was a revision surgery. So in group 1 without neuromonitoring device, primary surgery normal functioning was almost 88.9%, and for revision surgery it was 11.1%. And post-operatively at 6 months period of time, the revision surgery, the normal functioning of the facial nerve was around 3.7%. So with group 2 with neuromonitoring device, all the patients had some degree of facial nerve paralysis post-op day 1, but it has improved to 7.6 months over a period of 6 months. Coming to results, group 1 patients have higher degree of incidence of facial nerve paralysis than group 2. Group 1 patients had 37% of normal functioning in post-op day 1, whereas 72.8% had normal functioning in post-op day 2. And in group 1, 88.9% has recovered over a period of 6 months, and in group 2, 97% of the patient has recovered over a period of 6 months. So in conclusion, the anatomical information followed by surgical judgment along with intraoperative neuromonitoring device, we can reduce the morbidity, in improved quality of life to the patient, ease of comfort, it decreases the duration of surgery as well, and real-time status of facial nerve can be adjusted. Coming to limitations and lacunae, the cost, obviously we had just assessed the nerve injury based on House-Brackman scale. Clinically, we did not do any electrophysiological follow-ups with these patients, and false negative response of the neuromonitoring device can subsequently lead to nerve division, and there are no standard guidelines available for its use, and difference of sample size between the two groups, and interoperability variation between the surgeons. So acknowledgement, I would like to thank Dr. KDP sir for giving me this opportunity to do this analysis within a period of 25 days, I guess, and then present it to here. So I'll thank HCG Ahmedabad, Astha Oncology Associates, all my professors, and Dr. Duripala Reddy sir, who had given me this statistical analysis within a period of 2 days, I guess.
Dr. Mamta,
Yes, sir.
this difference of time frame, it was quite a bit, right? 1000.
Yes.
So whether the change result may be due to more experienced surgical team or anything, at least partly attributable to?
Yeah, it can be anything, because I don't have much experience in operating these patients.
What is your, how you look at it? Do you think that it can be partly attributed to
Yes.
that, more experienced surgical team and?
Yes, it can.
Better
It can make
yeah.
some difference, yes.
Maybe one
And
question.
I would like to ask one more question, because we have the House-Brackman grading scale. I don't think it is much accurate in assessing the patient clinically, because the complex branching and interconnecting of the facial nerve, I don't think it is very accurate. We must come up with some other scale which is more accurate for facial nerve grading.
And one more question I have. what according to you is the biggest benefit of intra-op now monitoring? One.
I think
and one limitation. One benefit and one limitation. According to you, which are those?
Okay. Benefit, I think for primary surgeries it may not be that useful, but revision surgeries, yes, it has some role compared to non-using this device in revision surgeries. And false negative response, as I said, can lead to subsequent nerve division, which we might not know.
Can we have Dr. Imran please for the next paper presentation, and next up would be Dr. Kartika.
Good morning everyone. I am Dr. Imran. I am a resident surgical oncology at GCRI Ahmedabad. My presentation today is on adenoid cystic carcinoma of the parotid gland. It was a retrospective case series. So the first description of adenoid cystic carcinomas was given in 1852 by Robin, Lorraine and Labumi Bean. It is a very rare tumor with the incidence of around 1% in the oral and maxillofacial areas, and predominantly it arises from secretory cells of the salivary glands. It can originate in other areas as well, like hard palate, nasopharynx, lacrimal glands, tongue, and other less common sites are breast, colon, prostate and female genital tract like cervix. And the overall incidence is 50 to 60% in minor salivary glands. Only 2 to 3% of tumors occur in parotid gland, making it a rare occurrence. Epidemiology wise, it is slightly predominant in females and presents in 5th to 6th decades of life. Etiology is not very clear, and unlike other oral malignancies like squamous cell carcinoma, smoking and alcohol use have not been linked as potential risk factors for adenoid cystic carcinomas in salivary glands. Genetics, the most frequently encountered deletion of chromosome 1p 3536 and translocation between chromosome 6q and 9p are found in more than 85% of these tumors. ACC, as we all know, is a locally aggressive tumor, and distant metastasis are also seen. Most common presentation of ACC is a slow growing, hard painless swelling in head and neck region with pain and paresthesias due to perineural infiltration, with highest rates of perineural involvement seen in tumors arising from the parotid gland. So most commonly involved nerve is the facial nerve. Most common sites of metastasis where hematogenous spread is lungs, bone and liver. Billroth described it in 1859 and termed it as cylindroma due to the cylindrical arrangement of tumor cells. And histologically it can be divided into 3 types: cribriform, tubular and solid. Grading of the tumor is grade 1, 2, 3. Grade 1 is cribriform and tubular component, grade 2 is solid component less than 30%, and grade 3 is solid component more than 30%. And so poorest prognosis is seen in solid patterns, which are frequently used to represent mitotic figures. Immunohistochemistry aids in diagnosis of ACC. The immunohistochemistry markers are actin, S100, vimentin and MYB and CD117. These all IHC markers help in diagnosis of the patients. Investigations use the CT and MRI. Surgery is the mainstay of treatment. Cervical lymph node dissection is done if the nodes are clinically positive. And despite good surgical technique, 5 to 10 year recurrence rate is 75%. And this is because of the perineural infiltration. And positive margins, PNI and positive lymph nodes are poor prognostic factors. So the aim of the study was to review clinical characteristics, demographic patterns, prognostic factors, treatment undertaken and local recurrence rates and outcome in terms of OS and DFS of adenoid cystic carcinomas presenting to our institute. It was a retrospective study. Data collection was done from 2016. All the patients of ACCs of the parotid gland treated at GCRI and treated outside and referred for further management were included in the study. A total of 30 patients were reviewed. Female to male ratio was 1.3:1 and 57% of the cases were female. Age range was 20 years to 80 years. Mean age was 48.1 years, that is fifth decade of life. And on presentation, the patients presented with either localized disease to the parotid. 40% of the patients had localized disease. 53% patients had locally advanced disease with lymph node involvement, like infiltrating to the skin, masseter muscle, pterygoid muscles, and 2%, two patients, that is 7%, presented with metastatic disease with lung and liver and bone mets. This is just a diagram representative of the clinical presentation. Nodal involvement was seen in 11 out of 30 patients, that is 37%. Loco-regional recurrence was observed in 8 out of 30 cases. Recurrences were associated with either with 3 of the following features, like locally advanced tumor on presentation, or PNI, patients having PNI present, and those patients who did not receive port. 3 out of 8 patients, 37.5% patients had recurrence who did not receive port. Surgeries performed were superficial parotidectomy. 22 out of 30 patients underwent superficial parotidectomy. 20% patients underwent total parotidectomy upfront, and 23% patients underwent total parotidectomy following a recurrence. Elective neck dissection was done upfront in 27% of the patients and 10% after development of recurrence. These were patients who were operated outside and presented with recurrence to DCRI and underwent total parotidectomy and neck dissection also. PNI was observed in 43% of the cases, and adjuvant treatment following initial surgery was radiation or combined CT-RT depending upon the final histopathological report. So mortality rate was 27%, disease-specific mortality was 27%, and non-specific mortality was 33%. Like one patient died of renal complications. 2-year overall survival was 96% and 5-year overall survival was 54%. Mean overall survival was 60 months and DFS was 54 months. So ECC is an uncommon tumor, and treatment includes surgery with or without adjuvant radiotherapy. Because of the rarity of data, the treatment is not very well defined, and there is insufficient evidence to determine whether an elective neck dissection is advisable or not. And nodal mets are shown to be a common cause for treatment failure, and there is no level 1 evidence whether elective neck dissection or post-operative radiation is mandatory. And some authors have shown that adjuvant radiotherapy can improve local control of the patients, and some have not found any advantage of it. One thing is clear, that poor prognostic features include locally advanced disease on presentation, presence of lymph node mets and positive margin during surgery, and presence of perineural invasion. These are my references. Thank you. Thank you.
What investigations do you use pre-operatively to judge and to predict for the perineural invasion?
Sir, MRI of the parotid gland is used frequently.
And if it is locally advanced, to start with, clinical
Yes.
presentation is locally advanced, do you go for PET scan?
No sir, PET scan was not. Like if we get a MRI of the oral cavity and neck region and CT thorax, that is the metastatic workup we do. And if everything is okay, we proceed with surgery. Depending upon the infiltration, local infiltration of the disease, if it is only involving the superficial part of the gland, then we do superficial parotidectomy, and if it is going to the deep lobe for margins, we can do total also.
What is adequate parotidectomy?
Adequate is, sir, with adequate margins, we remove and preserving the facial nerve.
So do you go for frozen section intraoperatively?
No sir, not routinely.
Okay, thank you.
Thank you.
Any questions from the audience?
Thank you.
Can we have Dr. Kartika, please? And next up is Dr. Meet.
So may I start? Good afternoon everyone. Myself Dr. Kartika, Senior Resident, MCH Head and Neck Oncology, AIIMS New Delhi. The topic I'll be presenting is a decade dissected unraveling oncological outcomes and clinicopathological profiles of 244 mucoepidermoid carcinoma cases. And the author is myself, Dr. Smriti Panda, Dr. Anchal Kakar, Dr. Rachit Sood, and Professor Alok Thakkar. The background, salivary gland malignancies fall in the category of rare tumors. Due to their heterogeneous nature in terms of pathological variants, there is a paucity of literature focusing on only one particular histological entity. So this study presents the long-term outcomes on a homogeneous cohort of mucoepidermoid carcinoma patients. Methodology, this retrospective cohort study queried into the hospital records on tertiary care center for histologically confirmed mucoepidermoid carcinoma cases treated over a decade, 2014 to 2024. Data on demographics, clinical presentation, clinicopathological characteristics, treatment approaches, and follow-up outcomes were meticulously analyzed. Kaplan-Meier survival analysis and multivariate Cox regression were employed for all the patients. I am directly coming to the results of my study. The study population is 244 with a mean age of 40.75 and with almost equivalent male to female ratio of 1.03:1, and all the cases underwent surgery, and 116 cases, that is 47%, received adjuvant radiotherapy. The median follow-up duration remained to be 39 months. The overall survival at 3 and 5 years stood at 89.6 and 87.4% respectively, while the disease-free survival stood at 87.4 at 3 years and 83.4 at 5 years respectively. And this is the descriptive analysis of the data. Majority were major salivary glands, 158 patients, and minor there were less, that is 86. Among the major salivary glands, majority were in the parotid, 127, and in the minor salivary gland, majority belonged to the oral cavity, hard palate being the most common site, and the least number went to the nasal cavity and the paranasal sinus. Coming to the survival analysis of all salivary gland mucoepidermoid carcinoma, when you compare the major versus the minor salivary gland, we can see the red depicts the minor salivary and the blue depicts the major, and there is a dip in survival, overall survival and disease-free survival for both the minor salivary glands, for both overall and disease-free survival. And in gender, there is no much difference that was noted. Coming to the minor salivary gland survival analysis, depending upon the subsite of the minor salivary gland, as depicted in blue picture, the oral cavity was said to have a better survival when compared to the nasal cavity and PNS, but it was not, both overall survival and disease-free survival was not found to be statistically significant. Coming to the histological grade, again low grade was having a better survival when in both terms of overall and disease-free when compared to the other grades. Perineural invasion of the minor salivary glands, the overall survival and disease-free survival was much better, and it was statistically significant in both overall and disease-free compared to the absence of the perineural invasion. Margin involvement in the minor salivary gland, again there is a statistical significance, and margin positive had poorer overall and disease-free survival. Coming to the major salivary gland data, again the site didn't play a major role in determining the survival in this. Even the grade played a role only in the disease-free survival, where it was statistically significant. And perineural invasion played a role even in the major salivary gland in terms of survival, with the presence of PNI having a poorer survival. Margin involvement played a role in the disease-free survival in the major salivary glands. Cox regression analysis were performed using parameters like clinical and pathological TNN stages, major and minor salivary gland involvement, and multivariate analysis was performed, and it was seen that the hazard ratio for death worsened with the clinical T stage and for the minor salivary gland involvement. Similarly, for the recurrence, hazard ratio worsened with the clinical T stage and minor salivary gland involvement. The most common pattern of treatment failure was loco-regional spread, noted in 4.98%, while distant metastasis was seen in 3.3% cases. This is a multivariate analysis which I have done, and it was noted that the clinical T stage, site and pathological bony invasion was associated with the poor overall survival, and gender, grade, clinical T stage, site, intracystic component less than 25%, pathological bony invasion was associated with poor disease-free survival. Coming to the discussion part, I have analyzed with other studies, and there is 2 studies which I found to be significant. There is mucoepidermoid carcinoma evaluating the prognostic impact of the primary tumor site, published by the MSKCC, and this cohort identified 308 patients of mucoepidermoid carcinoma who underwent surgery between 1985 to 2015 with a median follow-up of 73 months, and they found the 5-year survival and overall and disease-free survival to be 84 and 91%. And on multivariate analysis, the worst DFS was associated with higher grade tumors. In my study, I conducted 244 patients, again with a median follow-up of 39 months. 5-year survival and disease-free survival were 87.4 and 83.4% respectively. On multivariate analysis, the worst DFS was associated with clinical T stage and minor salivary gland involvement. And to conclude, the study findings reveal encouraging survival rates for head and neck mucoepidermoid carcinoma at 3 and 5 years. Demographically, mucoepidermoid carcinoma affects a broad age range with no gender bias, primarily manifesting in the major salivary glands. The treatment relies on surgery with adjuvant radiotherapy, while limited use of adjuvant chemotherapy was noted. Clinical T stage and minor salivary gland involvement emerged as significant predictors of survival, highlighting their crucial role in the treatment decisions. These are my references. Thank you, sir.
It was a very wonderful data which you have captured.
Thank you, sir.
Can you tell me whether this PNI was found to be more important than grade in one of the slide?
When I did the survival analysis, sir, I couldn't depict the minor salivary and the major separately. Even the multivariate I couldn't demonstrate it separately. But yes, sir, the grade was affecting the disease-free survival. Statistical significance was found both only in the minor salivary glands when it was analyzed separately. While in the major, it didn't. Grade was not. There were no statistical significance noted in the disease-free and the overall survival. But when I individually analyzed using Kaplan-Meier curves, for both the data, grade was significant.
Okay, thank you.
Were there any multiglandular involvement of MEC data included in this one?
No, sir. I have analyzed it all separately. It is not included in this.
Thank you.
Yes, sir.
Can we have Dr. Meet, please? And next up is Dr. Rajit.
Hello everyone, myself Dr. Meet Rojesra, resident at Surgical Oncology, GCRI Ahmedabad. My study topic is retrospective observational study of adenoid cystic carcinoma of salivary gland, that is except parotid gland. So adenoid cystic carcinoma, it was first described by Bill Roth in 1859 as cylindroma with its unique combination of connective tissue and epithelial tissue. ACC is known for its slow progression, local recurrence, regional and systemic mets. ACC represents approximately 1% of all head neck cancers and 10% of the salivary gland tumors. It is most commonly reported malignant tumor of the minor salivary gland, also one of the common cancers of major salivary gland. ACC can also involve the lacrimal, ceruminous glands as well as the other sites in head neck, including nasal, paranasal sinuses, trachea, larynx. It primarily affects the individuals aged 40 to 60 years with a slight female preponderance, more noticed in minor salivary gland tumors. ACC is a locally aggressive tumor characterized by perineural invasion and multiple local recurrences. The regional lymph node metastases are conventionally rare, that is less than 10%, but these may be under-recognized due to potentially occult, clinically undetectable cervical mets and infrequent neck dissection for this tumor. In sharp contrast, the hematogenous mets are more common, especially to the lung, bone and liver. Clinically, ACC is regarded as a high-grade neoplasm and consequently the treatment of choice is radical surgical resection and followed by postoperative radiotherapy. Chemotherapy, both the cytotoxic and the targeted therapy, has been extensively studied for advanced and inoperable or metastatic cases. Aim of our study is to review the clinical characteristic, histology, prognostic factors, treatment and long-term outcome of ACC of non-parotid salivary gland. It is a retrospective data collection done for the cases treated since 2016 at GCRI Ahmedabad having ACC of salivary glands excluding parotid gland. Patients operated outside with an external biopsy and referred for further management were also included. So total 22 number of patients were reviewed with an average age of 46.9 years and female to male ratio of 1:1. These are the variables. The site, most common site was the submandibular gland, then followed by the oral cavity and the sinonasal tract. At the presentation, 3 out of 22 patients were having distant metastasis at the presentation and 19 cases got operated. 7 out of that 19 cases underwent neck dissections. 18 patients on histopathological examinations had PNI, that is roughly 82%. Most common histological pattern observed was the cribriform plus a solid pattern, 18 out of 22, and only 4 out of 22 patients had a low grade pattern of pure cribriform or a tubular pattern. Out of the 19 operated cases, 3 had a positive margin on final histopathic examination and 3 patients had a positive lymph node metastasis. Adjuvant radiotherapy, patients, 12 out of 19 patients received post-operative adjuvant radiation therapy. Recurrence were noted in 2 cases. One was distant at lung mets at 2 years and one was the nodal at 1 year. And out of the 4 metastatic patients, only 1 received palliative chemotherapy. Regarding the survival, at 2 years, the OS and DFS were 89% and 84% respectively, and at 5 years, it was 58% and 53%. Discussion ACC, it's a rare malignancy with limited available data on treatment and survival outcomes. Our findings of this study, it contribute to the existing literature for better understanding of the disease biology. The proportion of ACC among salivary gland varies with the site and location of the primary tumor. Among the common found malignancies of the parotid gland, it is likelihood of ACC is even greater in the submandibular gland, where it accounts for about 40% of the tumors, and it is the most common cancer in minor salivary gland tumor, where the proportion ranges from 32 to 71%. And among the minor salivary gland, most commonly it is found in the hard palate, followed by the paranasal sinuses and the other sites of oral cavity. The average age of patients in this study was 46.9 years, which aligns with the previous reports that indicates ACC commonly affects individuals in their late 40s. Gender distribution of ACC among minor salivary gland shows a female preponderance with a female to male ratio variable across different studies, but in our study with the inclusion of major salivary gland tumor also the ratio was 1:1, but this reason behind this gender wise is unclear. There are 3 main histopathological patterns, cribriform, tubular and solid pattern. These patterns were used to assess the clinicopathological and prognostic attribute to each subtype. It was observed that solid subtype has least differentiated cells and denser extracellular stroma with an highly locally aggressive, and it shows the greatest frequency of PNI with poorest prognosis. The IHC markers was S100 and smooth muscle actin. PNI, that is the hallmark feature of ACC occurring in up to 80% of the cases. The phenomenon where the cancer cells invade the surrounding nerves and leading to a more complex clinical presentation due to nerve invasion. PNI in ACC, it has been linked with local recurrence, distant mets and reduced overall survival. The TEMO task, they reviewed 22 cases for PNI, and based on the features, they classified PNI in 2 groups, that is P1 and P2. P1 is where there is true perineural or endoneural invasion, and P2 is when the tumor was adjacent to the nerve and without invading them. P1 tumors had higher recurrence rates as compared to P2. The gold standard treatment of ACC that is deemed as potentially resectable, it is the radical surgical resection ensuring free margins and post-operative radiotherapy. But due to historically low incidence of occult nodal metastasis, that is about 17%, neck dissections is only performed in cases where it is clinically positive. Mean et al., they described a general incidence of lymph node mets in ACC of head neck cancer at almost 10%, which was more common in minor salivary gland. This author also noticed that primary tumor site and the peritumoral LVI were significantly associated with cervical lymph node metastasis. Then Lee et al., they recently reported 15.38% of the patients who received elective neck dissection had occult metastasis, and they recommend performing elective neck dissection for staging and achieving regional control. But it remains unclear whether this regional control, whether it will improve the survival or not, whether the elective neck dissection versus the primary radiotherapy, the advantage is not clear. The low long-term survival rate of ACC patients is uniformly linked to the failure to control the distant disease, and these distant mets occur more frequently in the lung with only possible treatment of palliative systemic therapy. Reported prognosis, it varies widely, mainly because of the different reports and different quality and length of follow-up. The large European study, they show a 10-year overall survival rate of about 65%. The other study, the 5, 10 and 20-year survival rates was 68%, 52% and 28% respectively. Yuang et al., they reported overall and recurrence-free survival rates at 3 years. It was 84% and 58% respectively, while the rate of survival with recurrence was 26%. After 15 years, the overall survival rate was 24.5% and the recurrence-free survival rate was 22.6%. These findings are comparable to our patient group with DFS and OS at 5 years of 53% and 58% respectively. So, in the conclusion, the preferred treatment modality is the radical surgery with adjuvant radiation. The role of elective lymph node dissection to detect the occult lymph node metastasis is unclear, and whether these lymph node dissections provide survival benefit or it can be avoided by adjuvant neck irradiation. We need a larger scale studies with a prospective randomization to prove, and ACC further develops delayed distant metastasis even without a loco-regional failure, which needs a long-term follow-up and further advances for systemic therapy for the management. These are my references. Thank you.
How many patients out of your 22 patients in the case series were offered pre-operative PET scan?
No sir, they were not offered pre-operative PET scan. Most of the patients were referred to us after the excision biopsy done outside. Majority of patients, more than 50%,
Excision biopsy
was done outside, and after the histopathological examination, they found out to be an adenoid cystic carcinoma and referred to GCRI. But the patients which were diagnosed at GCRI, we did the CT thorax for the metastatic workup. We did not offer any
and
PET
out
scans.
of those 7 patients which were subjected for elective neck
Lymph nodes,
dissection due to clinically positive nodes, what was the rate of histopathological positive nodes?
Only 3 patients came out to be positive, that was 52%.
Okay. Was any pre-operative FNSC was done, performed in those
no
cases?
Sir, no sir, not done in any cases. They were image guided suspicious nodes in which we selected for the elective neck dissection.
Okay, thank you.
Can we have Dr. Rachit on stage, please? And the last one next would be Dr. Shivank.
Good afternoon, respected all. I am Dr. Rachit. I am a head and neck resident at AIIMS Delhi. I'll be presenting our experience in deciphering malignancy risk profiles in unambiguous Milan categories of category 3 and category 4B. So management of salivary gland tumor is challenging, and this challenge begins right from the time when the patient presents to us, as there are a lot of overlapping clinical, radiological and cytological features that overlap benign and malignant behavior. Though basically they are 0.5% of all the malignancies and they form 6 to 8% of all the head and neck cancers. As we know that 80% of these are benign, but this 80% belongs to all the cytological categories. They have a diverse histology and they have a diverse behavior, from being low-grade tumors which have 5-year survival rates of up to 90%, and they go as low as 40% when concerned with high-grade tumors. So there have been certain clinical presentations, radiological features and cytological features which have a certain overlap in both the benign and the malignant categories. The cytologies of Milan 2 and 4A have significant lower risk of malignancies, whereas 5 and 6 have higher risk from 60 to 90%. But the Milan category 3 and 4B trouble us the maximum, as the risk of malignancy lie in the indeterminate categories. The basic challenges in this, basically first is that the incidence is low and they do have a high rate of recurrences, and the revision surgery is very challenging, as has been discussed over the past 2 days, that the risk of facial palsy increases from around 3.9 to up to 40% in revision cases, and this also attributes to the diverse histology. Hence these tumors require a very exhaustive and a comprehensive workup preoperatively. So the 3 main challenges: one is that they are relatively uncommon. They are 28th, they rank 28th in incidence of all sites of cancer, but half of these are in the Asian subcontinent. And its rare incidence also limits the availability of good quality evidence as well. The second challenge with these is the diverse histology, as they have a multicellular histogenesis, and according to the 5th edition of WHO classification, there are around 39 variants of salivary gland tumors. And the third is the varying risk of malignancies. This meta-analysis published in 2020 by Jalali et al. Reviewed 37 articles with 8,000 plus cases with a histological follow-up, and it showed a mean range of malignancies in Milan 3 and 4B to be around 39.2%, which was similar in both the categories. Our study objective was to review post-operative histology, specifically in Milan 3 and 4B categories, and to somehow establish some associations with their clinical, cytological and radiological factors that can help us predict the risk of malignancy. All the FNACs done at our institute were reviewed from 2018, from where we started reporting Milan categories up till June of 2024. Out of these, Milan 3 and 4B were segregated, and they were reviewed retrospectively for their clinical, cytological and radiological features. We also divided Milan B, as it has now been subcategorized into 3 major types: the oncocytic variant, which have large cells and a lot of cytoplasm with a low nucleocytoplasmic ratio. The second subcategory is basaloid, which have comparatively lesser amount of cytoplasm and a high nucleocytoplasmic ratio. And the third category belongs to clear cells, myoepithelial cells, so it is categorized as not otherwise specified. The type of tumors also vary from oncocytic to basaloid, as we can see that oncocytic is more commonly seen in Warthin's tumor and basaloid in pleomorphic adenoma. A total of 616 FNACs were reviewed, out of which 19% of these were Milan 3 and Milan 4B, and the post-operative data was present for 106 of these. The mean age was 47.3, and there was no gender or age preponderance in our study, majority belonging to the parotid gland. We had around 18 different histologies in our 106 patients, most common malignant being adenoid cystic carcinoma and mucoepidermoid, and benign being pleomorphic adenoma and Warthin's tumor. We also compared the risk of malignancies between Milan 3 and 4B and various subcategories of 4B, basaloid, oncocytic and other, but we could not establish any significant difference. However, Hang et al. Had found a significant difference in the risk of malignancies in these categories. We also saw that a repeat ultrasound guided FNAC in Milan 3 categories help us to define these tumors in a certain definite categories in up to 88% of these patients. We analyzed the clinical predictors of malignancy. The significant relation that we found was in presence of pain, presence of facial palsy, and presence of a fixed swelling preoperatively. The radiological features that we found to be having significant association with the risk of malignancy was the presence of T2 hyperintensity, the presence of irregular margins, the presence of infiltrative margins, and radiological lymph node present. A simple malignancy test has been defined by Hang et al. And that involves the combination of a T2 weighted hyperintensity and the presence of irregular margins. Here we can see in the first tumor, the first image, that it has a T2 hypointensity with some irregular margin. This was adenoid cystic carcinoma compared to a T2 hyper intense on the second, that was pleomorphic adenoma. We also encountered a bilateral hyperintense as seen in the first image, that was histology for Warthin's tumor. In the second image, we see a hypointense T2 tumor with an infiltrative margin, also loss of fat planes with the subcutaneous tissue. The diffusion weighted MRI also has a significant role in determining tumors, with malignant tumors having high intensity on diffusion weighted imaging. The role of IHC, we could reach to a definitive certain diagnosis in 16 of our cases, MYV positivity showing adenoid cystic carcinoma, androgen receptor being very specific for salivary duct carcinomas. The merits were that we were aiming specifically focusing on indeterminate categories. The demerits were a small sample size and a very diverse histology amongst it. So the indeterminate categories, they form 20% of all tumors. A guided FNAC helps in Milan 3, and the clinical and radiological predictors can help us certainly to reach somewhat a narrow differential diagnosis. Coming to briefly about a future direction, there have been multiple articles further subcategorizing Milan 4B, which can help us later in the future. And there are also classification of time intensity curves based on diffusion weighted imaging. And there have been certain reports of developing a machine-based normogram that can predict the risk of malignancy to a certain extent. These are my references. Thank you.
Slides were reviewed by pathologists, right?
Yes.
And
The outside slides were reviewed in our.
and even inside slides were reviewed by pathologists to do this paper.
Yes, yes, sir.
So they were blinded to the original FNAC report and path report? Or they,
Sir, sorry, the FNACs done at institutes were not further reviewed. They were initially reported as basaloid, oncocytic and the third category, but all the outside reports were reviewed.
okay. Thank you.
What were your indications to go for core cut biopsy over an FNAC for the Milan 4B category for subtyping?
Sir, there were core biopsies was done only in 3 of our patients, and 2 were actually, they came out to be lymphoma whenever there was a suspicion of lymphoma. Otherwise, for a guided FNAC, we were able to categorize in a majority of our patients.
Okay, thank you.
Can we have Dr. Shivang, please?
Good afternoon, everyone. I'm thankful for the organizing team to give me an opportunity to present amongst the stalwarts. I'm going to talk on this unique entity known as mammary analog of salivary carcinoma. So this is a malignant salivary carcinoma which resembles secretory carcinoma of the breast. It was first described by Scalova et al. In 2010, and it is often misdiagnosed as actinic cell carcinoma. So this is my question to the audience. How many of you have encountered this entity in your clinical practice? Okay, I can see few hands are going up. So the incidence has been increasing over a period of time. This paper by Luke et al. Reports it at around 5%, while Chiosia and Jung et al. Have reported it at 9 and 6%. And most of these have been a retrospective diagnosis of actinic cell carcinomas or adenocarcinomas or mucoepidermoid carcinomas. Scalova et al. Described this new entity in 2010, while WHO published this in its 4th International WHO Head and Neck Classification in 2017, and most of them were again retrospective evidences diagnosis of actinic cell carcinomas. Coming on to AJCC classification, T1, T2, T3, T4 is less than 2, 2 to 4, more than 4 and involving adjacent structures, while the N classification is same as that of other head and neck tumors. Now again a question to the audience, how many of you think that MAC behaves as a low grade tumor? So this, okay, sir believes, and others then believe it's a high grade tumor? Okay. So first of all, why is this grading important in salivary gland neoplasms? So according to the recent NCCN guidelines, if it is a T1, T2 lesion and when it is completely resected, and on the final histopathology if we find adenoid cystic or high grade changes, then adjuvant radiation is preferred. Similarly for other major salivary gland tumors, when clinically N0 and we find a high grade histology, neck dissection is warranted, and after completely resected, if there is a high grade transformation found, again adjuvant radiotherapy is preferred. So it is important to we know that whether this entity behaves as a low grade or it behaves as a high grade tumor. So this is a paper by Evan et al. Where the author states that 90% of the mammary analog of salivary carcinomas, they actually behave as a low grade tumor. In her landmark paper by Scalova et al., she described this unique ETV6 and NTRK gene fusion for this entity. This basically causes uninhibited tyrosine kinase release, which is causing cellular proliferation. So let me just simplify this with the help of a diagram. So secretory carcinoma is one type of invasive breast carcinoma, And in this carcinoma, this ETV and NTRK translocation is found, which causes tyrosine kinase release, and hence this entity has been named as mammary analog of salivary carcinoma. So this was one paper which we published in GCRI. We had 5 cases. All the 5 cases had mammoglobin positivity on IHC. Rest we found S100, CK7, CKIT, P63, MUC4 and cyclin D1 mutations. This is again a table from the same paper. We had 5 patients. 4 patients had parotid involvement, while 1 patient had a submandibular gland involvement. Skin was involved in 2 patients. Facial nerve clinically was normal in all of the patients. All the patients underwent preoperative staging with an MRI. 2 patients underwent total parotidectomy, 1 with facial nerve preservation, and 1 patient underwent neck dissection. And 2 patients underwent, neck dissection was done as it was just a submandibular gland involvement, and 2 patients underwent superficial parotidectomy. Adjuvant radiation was given to 1 patient, while 2 of the patients defaulted on adjuvant therapy, and in 1 patient we had recurrence at 9 months, most probably because he had defaulted on the adjuvant treatment. Now comparing our case series with other international studies, our series is the second reported series from India. The first was a series by Nisar et al. Where he had reported around 3 patients. In our series we found a mean age to be a little lesser as compared to other series. The male to female ratio was similar, while in our series 1 patient had developed recurrence. This is traditionally a low grade carcinoma, but in our series we actually found 2 patients had skin involvement, which suggests that it can be a high grade carcinoma. So I feel there is a dearth of literature and we need to present more and more papers on this topic. Now this is a basic algorithm for salivary gland tumor management. Initially we would do imaging followed by fine needle aspiration. On the aspiration FNA cytology, if it is a benign or a low grade tumor, then a conservative surgery is advised, and on the final histopath, if it's benign, we will follow up. If it's a low grade malignancy, then we will again look for other high risk features if at all present. If not present, then the patient is followed up, and if high risk features are present, then adjuvant radiation is warranted. For high grade malignancies, we will work them up for metastasis, followed by adequate parotid surgery and a neck dissection. On the final histopathology, then we'll again give adjuvant radiation if it's high grade, and for low grade tumors again we look for other any high risk factors present. If present, then radiation is warranted, and if not present, then we can follow up our patients. This is one paper by Lucas et al. Where he has mentioned that sometimes high grade transformation is possible in such patients. High grade transformation usually occurs whenever there is a WIM-RET gene. This WIM-RET gene basically codes for vimentin, which is a cytoskeletal structure, and vimentin is thought to cause epithelial to mesenchymal transformation, which causes high grade transformation in these tumors. And this WIM-RET gene can also act as a target for treatment. So this can be one of the future treatments for these patients. So I would like to conclude that this is a rare entity which is characterized by ETV6 and NTRK translocation. IHC is actually a cost-effective way to diagnose these entities, and it usually behaves as a low-grade salivary gland. And this is what we had also concluded from the paper, that IHC is cost-effective than genetic studies, and in our institution we usually diagnose them on IHC. Thank you.
Okay, Shivang. Do you know law of small numbers?
No, sir.
That is an interesting chapter in a book by Daniel Kahneman. That if numbers are small, then it is difficult to make too many conclusions from
Yes, sir.
those numbers. Thank you anyway.
Can I ask a question?
Yeah, please, sir.
So mammary gland is apocrine or does it make any difference?
What, sir?
So mammary gland is an apocrine gland.
Yes, sir.
And the salivary gland is. So because of that there is overlapping.
So there is a secretory carcinoma in breast.
There are three types what we have been taught: apocrine, merocrine, and holocrine.
Yes, sir.
So does it make any difference in this because of the variant of secretion it causes? Just I am asking for my knowledge.
Not sure, sir.
Thank you.